Exam 3 a week from today. Study guides are posted on Canvas. There's a few more resources, like a Kahoots and some other things. We're going to hear from the TAs and the SI on review sessions that are coming up. You know the drill. 5 points for attending one of those sessions, either in person or by Zoom. Quiz 8 is due this Friday by 11:59 p.m. And there's a number of you that emailed me about some quiz textbook issues. I think we got that all straightened out. So if you haven't heard back from me, it's probably because you sent the message like maybe after 3:15 today or 3 o'clock, and I haven't read it yet. All right. Any other housekeeping things that we need to cover? All right, so can we hear when are the sessions for review for exam 3? And the exam is not Monday, so you have a little extra time, okay? So Mondays we'll have a lecture and it'll be material that's eligible for the exam, but it'll be a lighter lecture.
Hey guys, so my SI session next Wednesday from 11 a.m. to 12 p.m. is going to be dedicated to exam review. As of now, we're in Science Annex 117, but I'm trying to get a bigger room, so I'll let you guys know if we end up moving.
We have our joint session this Sunday from 3 to 4 p.m. in Bio Room 256. Then I'll have my session right after the Monday lecture, 5:30, 6:30, Bio Room 155.
Yeah, and my review session is tonight from 5:30 to 6:30 over in Bio 145 as well.
You're not going to do one next Wednesday after the exam?
I'll think about it.
Okay. Catch all that? So we'll put this on Canvas as well. But now you guys should be in the know. Okay. What stays in a corner but travels around the world? Who said it right here? A stamp. Well done. What kind of animal would you never play video games with? A cheetah. Oh, man. What did 0 say to 8? What did 0 say? What? Nice belt. 100% today. You guys are ready for the exam next week. I'm so happy. That makes me so happy. All right, well done. Okay. Central nervous system. We're going to kind of finish out brain today, and then we're going to do a few kind of review questions. I'll set up some of the worksheets that I think you guys should study that could be helpful for next Wednesday's exam. And then we're going to move in the second half of today into the spinal cord. And then we'll have a little bit of material to finish up on Monday, but we'll get done early on Monday. But today you're going to want to stay the entire lecture. Those are one of my not so subtle hints. So we're going to look at some additional structures of the forebrain, the front brain. We're also going to look at some additional structures of the diencephalon. And today, as we kind of work our way through, the thalamus, that surrounds this third ventricle. And the ventricles, how many are there? 4. Well done. And what do they have inside of them? Cerebral, spinal fluid. Nicely done. And where's the cerebral spinal fluid made? In the ventricle specifically. What structure? Sounds like oroid, choroid, rhymes with exus, plexus. I know I'm horrible at this game, right? Choroid plexus? No, that wasn't obvious. What is the choroid plexus? What is it? It's a vascular network that serves as a filter location because cerebral spinal fluid comes from where, ultimately? From the bloodstream. It's filtered blood. We looked in the skin at other things that were filtered blood. What was it? Do you remember? Back to the skin, the integument? Sweat. Nicely done. So, do you see this theme? Like the circulation of fluid around our bodies in the vascular system, it goes to certain structures and then you can filter out what you need. So, the ventricle, just a little bit of a review from the last couple lectures. This is a relay center, the thalamus. The thalamus is a huge relay center. And it's taking information from the body on its way up to the cerebral cortex and receives all of this incoming information and distributes it out into the specific regions of the brain where it's necessary. So think of it as a giant relay center. It connects to the hypothalamus, and you're going to cover more of the thalamic physiology in 202. As you talk more about the thalamus and the hypothalamus and these axes of endocrinology, that they release certain types of signaling molecules that give rise to different things in the endocrine system. Like it'll regulate metabolism. It'll regulate sexual gamete function. It'll regulate sugar levels in the blood. The hypothalamus, hypo meaning underneath, so it's just underneath the thalamus. You can kind of see the arrow is just below it, hypo meaning below or under. This is a really important center, and again, in 202, you'll unpack the thalamus and the hypothalamus and how they interact in more detail. But for purposes of this semester, I want you to appreciate, in other words, know this list of things that the hypothalamus is responsible for. So hypothalamic control controls thirst. It controls your water balance, which is tied to thirst, obviously. So when you feel thirsty, and all of a sudden I feel thirsty because we're talking about it, it's your hypothalamus that's actually giving you that input, telling you you should have a sip of water. Pleasure centers, rage or anger, sexual desire, appetite or satiety centers, otherwise known as hunger, sleep patterns, your temperature, and other types of emotion that are kind of tied to rage, like aggression. So trauma to the hypothalamus can impact any one of these things, or a stroke to the hypothalamus can impact any one of these things. Malformation or disease of the hypothalamus can impact any one of these things. All right, next up, we're going to look at, in red, the pituitary gland right here, and in green, the pineal gland. The pituitary gland sits in the hypophyseal fossa of the skull, and it contains hormones that regulate growth, blood pressure, pregnancy, sex organ development, and a few other things. And so the way this works is the thalamus talks to the hypothalamus talks to the pituitary gland. You actually have two pituitary glands. You have an anterior in the front, and you have a posterior in the rear. And those two organs, the pituitary gland, the anterior and the posterior, you'll unpack in great detail in 202 in the endocrinology section. And the endocrinology organ is really the pituitary gland, but it's under control by the hypothalamus and the thalamus. So, for example, if individuals, let's say, for example, are of short stature, or an individual is really tall, we refer to this as a pituitary disorder, potentially. So if they're really, really big, it may be referred to as pituitary giganticism. And there was a famous individual in the 80s who was a WWF wrestler who had pituitary giganticism. Do you remember his name? Andre the Giant, exactly. And the growth hormone that was being released because of the pituitary gland was elevated, and he was just a huge individual. Now, the flip side can happen for individuals that are short in stature. Is not enough of that growth hormone is being released, and their development may be slowed, or they may be just smaller in size. But this is the organ that regulates that. Okay? So in pediatric medicine, it's actually really challenging because in some cases, for pituitary giganticism, it could be a tumor that's in the pituitary gland. It's an active tumor, so it's making extra growth hormone that's being released. Okay? And so that tumor has activity and contributes to the disease state that's being manifested. All right, so more on this in 202. And then if you continue with me in 320 in pathology, we talk a lot about endocrinology diseases, and we'll cover some of the ones that we just mentioned. Shifting over to the posterior aspect, remember, here's the cerebellum. So you know this is the back. Here's the forebrain. Here's the brain stem. This is our pituitary gland. This is our pineal gland. The pineal gland secretes a compound known as melatonin, which is released during your dark cycle when the sun is down. Melatonin, which is spelled differently and is not the same substance as melanin, right? Commonly misspelled and commonly confused, as you can see why. But melatonin kind of controls your circadian rhythms or your sleep patterns, and it actually makes you drowsy when it's released. And so the concept is the sun drops, the pineal gland starts secreting melatonin, and you start feeling drowsy as the night goes on. Now, there's over-the-counter melatonin for people that, have trouble sleeping or work graveyard shifts or for jet lag. They say that it's not pharmaceutically addictive, but everything behaviorally can become addictive. Does that make sense, the difference there? You get into a habit of relying on it. But it's not a narcotic, it's a natural occurring substance. So of the things that you could have to help you sleep, it's probably one of the better ones. All right, the hindbrain and the midbrain. So the hindbrain, the cerebellum, the medulla oblongata, and the pons. Cerebellum, here's the pons, and then down here is the medulla oblongata. So let's take them one at a time. The hindbrain, just to remind you, we're at the metencephalon plus the diencephalon. The metencephalon is the pons and the cerebellum, and the diencephalon is the medulla oblongata. Right? These, dinosaur-like terms are from the original Latin. They give you clues as to where things are located. But again, my promise to you is on the exam, you won't see these terms of cephalons. You'll see pons, cerebellum, medulla oblongata. Fair? The cerebellum is referred to as the little brain. It's our hallmark indicator of where what position the brain is oriented. And it's got these natural identifying, features. So if you slice through the mid sagittal view, you'll be able to see that there's this white matter that kind of extends out. I think it looks like a piece of cauliflower. And this white matter is referred to as the arbor vitae, which translates in Latin to the tree of life. The function of the cerebellum is the coordination of muscle activity, and it helps with postural control and the passage of time, conceptualizing the passage of time, like we talked about in the very first lecture. If we look grossly at this top image, you can see right down the middle or the center that kind of connects the two hemispheres is this vermis. And you've got, anterior lobes and posterior lobes, but you also have, it's bihemispheric. You have two hemispheres. You've got these ridges that we refer to as folia instead of gyri. So little brain has a lot of characteristics like the cerebrum, but really the main purpose of it is muscle control and posture and the passage of time, or conceptualizing, what did you do last week over spring break? What are you going to do differently next year on spring break, right? Or how long are you going to be spring breaking, right? Just in college, or are you going to keep going, right? So forecasting into the future. Thinking about next Wednesday. That's the cerebellum, is projecting into the future of next Wednesday, right? The medulla oblongata. So we're going to go down to the medulla, and then we'll come back up to the pons. This forms a component of the brain stem. So what were the three axes that I shared with you of the way the brain is organized? What are the three different axes? Who can share with me one? Right to left. Thank you. Can you give me some ideas of things that are focused on the right side of the brain versus the left side of the brain? Any examples? On which side? The right side, the feelings, the emotions. The left side? Logic, math, science, reasoning. Okay, good. What's another axis? What's that? Front to back. Front to back. I get my cerebellum working, right? Front to back. So what's towards the back? What information is organized in the back of the brain? Sensory information comes in the back of the brain. And as it moves forward, it turns into what? Motor, or a decision, right? The cerebral cortex, the frontal lobe, is all about decision making, right? You're processing information up here. You're deciding if you're going to say something, right? You're deciding if you're going to respond or do something. You're deciding if you're going to unload the dishwasher or pick up your dirty socks, right? That's all the forebrain. What's the third one? Axis. Up and down. It's true, it's correct. I'd like some more anatomical-like terms, but that is not incorrect. How else could we define that anatomically? Superior, inferior. What's another way? I used 2 C words to describe it in the lecture. Cranial and caudal. Well done. Cranial and caudal, meaning tail. That's why I pointed to my butt, right? So here on the axis, where does the medulla sit? Left, right, back, front, cranial, caudal? Caudal. So is it more higher thought processes or more automatic functionality? Automatic functionality. That's what the brainstem is doing. So if you look here, it says automatic functions like cardiac and respiratory centers. Like when you're sleeping at night, you are not consciously awake because you're sleeping. Melatonin is on board from your pineal gland, but your heart rate continues. And you still breathe, thank goodness, throughout the night, right? And you don't have to think about it. Right now, you don't even have to think about it, right? You're not like, breathe, breathe. Wednesday of next week, you may have to tell yourself, breathe, breathe, right? But right now, you don't. Now, you can override autonomic functions, and you can control that with conscious activity. But the automatic capabilities of the brainstem is a great example of this cranial to caudal axis that we're trying to portray. So this adjusts the heart rate. You have reflex centers here. Reflexes are automatic. We're going to learn about reflexes a little bit on Monday, and then we'll come back to them, bless you, on the next unit. But reflexes for coughing, sneezing, gagging, swallowing, vomiting, salivation, and sweating, right? Some of these things, these are just reflexes that happen that you cannot control, right? You walk into a room and it smells like puke and you're like, right? You're like, oh my gosh. That gag reflex, because you smelled something that smells like vomit, right? That's the medulla oblongata. The pons. So we're moving a little bit superior here. We're just moving back up a tad, but we're still in the brainstem. This relays signals from the cerebellum to the cerebrum. So it's going from the cerebellum to the cerebrum, and the cerebrum back to the cerebellum. It's associated with sleep activities, hearing, equilibrium, taste, eye movement, facial expressions. breathing, swallowing, and bladder control. So again, a mix. It's a little bit superior to the medulla oblongata. So you've got certain things that are involuntary and certain things that are more voluntary control at the level of the pons. You kind of have this mix because you're in the brainstem, but you're a little bit more superior. An interesting fact that I forgot to bring up on the medulla oblongata is because of its control over respirations and heart rate, this is actually the location, if the noose is fashioned correctly to snap the neck on a death by hanging, it fractures the medulla oblongata and the individual's heart rate stops and their respiration cease. So you don't really suffocate them by like strangling them. Does that make sense? Like that old way of capital punishment, they thought a lot about this, I guess is my point. It also happens to be the location for snipers to aim at the base of the skull to take out a target with a one shot, one kill. Okay, because of its location and what it does. Yeah. Well, I was never at a public hanging, but my if I may go off script slightly, my guess is there were times in public hangings where it was done correctly, and there were times where it was probably done incorrectly. Does that make sense? Yeah, and those were probably a little bit more horrific or more entertaining, however you sit on that spectrum. Okay. Well, people came to watch, right? That was kind of weird. That's a weird part of society, in my opinion. But sometimes we humans are weird. So, okay. The midbrain, mesencephalon. Mesencephalon. So as we look at this mesencephalon, we've got 4 hemispheric processes that we refer to as the corpora quadrigemina. And we've got structures known as the superior colliculi and the inferior colliculi. So we're here in the midbrain, and this is the superior colliculus, this pair of bumps, and the inferior colliculus is this pair of bumps just below it. And these two structures are quite interesting. The superior colliculi allow for the tracking of moving objects visually, right? So this is, you're outside, you're on the pedestrian path, and one of your friends comes by on a skateboard, and you can track and identify that that's Tony. Like the superior colliculi help you track objects visually. Very valuable capability. Does that make sense? So if you think of the analogy, like I always like to compare the human body to robotics, because robotics and machines, right? Now we're in this age of AI, and we're putting AI into robots, right? And what's one of the things that we want with both of those modalities? Maybe we don't want it, but that's what the field is trying to achieve. What is their goal with AI and robotics? To make it more like what? More like a human, right? So AI now, this is kind of an interesting sidebar. This paper I just read, some of the best AI that's hard to distinguish if it's really a human or if it's AI are the ones that actually will lie on occasion. They'll tell a small lie to make it more human-like. That's a sobering thought, right? And with robotics, everything like your camera, you got these phones and they have like all these, cameras, and all these cameras are to try to make it faster, focus quicker, take a sharper image, right? And make it look like a picture that you would see with your eye. The ability of the human eye to focus is faster than any camera. Processing, these computers, right? We want them to be as fast as the human brain or faster. Computing power. So back to the story, the superior colliculus, from a robotic standpoint, right? If you're on the pedestrian path and you're walking and somebody comes by and you got one snapshot, it's hard to identify versus if you can track the whole time. And that's the purpose of this structure, superior colliculus. Okay? Going to be really important for robotics to mimic, because that's that movement instead of like, right? That looks very non-human like. It's just this nice smooth moment of, oh, hey, what's up, Tony? The inferior colliculus, this is for auditory. Similar concept, but this allows for you to track auditory from the brain, giving you information on, in a similar way to the superior colliculus with vision, giving you information of, is that sound coming towards me or is that sound going away from me? Which is an interesting experiment, because if you ask like a 5-year-old when they hear a siren, and you ask them, is that getting closer or further away from us? 9 times out of 10, they will be able to answer that question because it's built into your brain in the inferior colliculus. Right? It's just physics, right? You guys remember that from physics? How the sound waves are either getting tighter or they're getting further away. But your brain just interprets this automatically. And a 5-year-old can tell you that the ambulance is getting closer or further away. The colliculi, the hills, because they're these little bumps. Yes?
I have one question for the easier. Is that used to recognize voices too?
Recognizing voices, like pattern recognition, it does help with that, but not solely alone. So the auditory cortex is going to be responsible and shorter long-term memory, like in the limbic system. So all of those centers will work together for when you hear someone's voice, you say, oh, that's my friend, fill in the blank, or that's my mom calling, right? So these centers are involved, but not independently by themselves. Okay, last up, the reticular formation. So this reticular formation, as you can kind of appreciate from the very, vague diagram of blue arrows, this reticular formation is not a well identifiable track system. You can't pinpoint it. You can't point to it like you can with the cerebellum. You can't point to it like the motor cortex or the sensory cortex. The reticular formation is a loose network of gray matter that spreads throughout the brain stem and into the cerebrum, so vertically, and it helps to coordinate the control of all sorts of activities like somatic motor control, cardiovascular, pain, sleep, consciousness, and habit-forming activities that you do. This is the reticular formation. So this actually intersects many different parts of the brain as information moves from the spinal cord out from your environment through the spinal cord to the posterior aspect, and then as it moves towards the forebrain. Questions? Yeah, so the question is, why are habits difficult to break? And so the simple answer is like what you said. Habits are actually depositing information and using a variety of centers in your brain. So pick a habit. You get nervous and you bite your nails. Just pick one, right? So the nervous portion is part of hypothalamic outflow, right? There's going to be sensory information. You're nervous because you saw something, you heard something, you're in a certain environment. And so now that sensory information comes in, the posterior aspect to the postcentral gyrus, the somatosensory cortex, sends information to the hypothalamus, makes you nervous. You hear a sound, you've got something coming from the auditory cortex, right? It may hit the inferior colliculus, and then it goes to the motor center, and then your frontal cortex says, well, when I see that person in this room, I feel anxiety, right? And then you start chewing your nails. So yeah, you're exactly right. Like I just described like 6 or 7 different locations in the brain where information is all talking to each other because somebody walked in the room and said hello. All right. Let's continue on. But we're going to continue on first with a little bit of a review. So I'd like you to answer this question about the precentral gyrus. Don't shout it out quite yet. I want to take a volunteer. So just think through it a little bit. So who's got an answer for us that would like to take a stab at it? Is it E, directing motor movements? It is E. Why is it E? Oh, just anybody, yeah. Why is it E? That's correct. Because the precentral gyrus is the motor cortex, right? Controlling motor function, directly corresponding to answer E. Okay, how about this one? 67-year-old woman experiences a stroke to her right temporal lobe. Which of the following will most likely result from this permanent damage? Now, clearly this is a horrible test question because there's not F and G on your Scantron, but it's okay. So what are the important words here? Shout out some words that are important. Temporal, right? Permanent's probably important, I would guess, right? Okay. So who's got an answer for us? And then, of course, I'm going to ask the question of why. Yes, right here. G? Which one? B and E. Loss of vision in the right eye and loss of hearing in the right ear. Okay. You guys agree with that? It's a right side stroke. So what do you think about what it'd be the opposite, okay? Right? Because we got to cross over like I told you, right? So it's going to affect the left side. So now what would it be? Well, we got a temporal lobe. So what's happening on the temporal lobe? Because the eye is what? What's that? Occipital, yep. The occipital lobe. Yeah, it's okay. You'll spell it correctly if you say it that way. That's what I always say. Yeah, but teach, I spelled it right? Yeah, but you said it wrong. It's like, well, that's how I remember how to spell it. Okay, so which one is it? It is G. So F is loss of hearing, I agree, in the left ear, because the temporal lobe manages hearing. And what's the other one? Gustation. What's gustation a word for? Taste. Temporal lobe. Okay, tough question, right? Because you got to remember it goes from the right side to the left side. Then you got to remember like what the heck the temporal lobe does, right? And then you got to think through like this patient had a stroke. That's a tough question. And then you got to make your own bubbles because my answer key on the Scantron only has up to E, right? Just kidding. Okay, how about this one? A brain lesion. A patient has a brain lesion, never feels full, and continues to eat so much that she now weighs nearly 600 pounds. The lesion is most likely where? A. Wow, you were very confident on that one. We got agreement? Yes, I would agree. Why? That's the satiety center. That's the center that tells you you're hungry, or your satiety, your satiation is just a word that means that you feel full. It's that sense after a meal of like, oh man, I'm full. That's satiety. That's controlled by the hypothalamus. So this is a real medical situation in a lot of patients, right? Where they have hypothalamic lesions and they just cannot control eating. They just continue to eat. Okay, game on, the exam. You should know this list. We covered every single one of these things on this list. Right? You should be able to label these on a brain picture like this, for example. Okay? If that is not the world's largest hint, I don't know what else to tell. I don't know how to help you. And here are the answers. Okay, yeah, get your phones out. That's fine. All right, here we go. Just want to be on your Snapgram. All right. I say that all the time. My kids say it's not funny, but you all laughed. And I have video recording that it was funny. Okay, what are some of the functions of these? Do you know the functions of these? I think some of you do, because some of those questions that we just dissected were based upon your knowledge of occipital lobe. How did you say it? Occipital lobe. Yeah, occipital lobe. I like it. I like that. Occipital. That's how the Kiwis say it, occipital. Yeah. The New Zealand. I just made that up. All right, interior brain parts. Interior brain parts. Do you know this list? Okay. This is kind of like, a study guide in a way. Questions before we shift gears out of the brain now to the spinal cord. So we're still in the central nervous system, folks, but now we're in the inferior portion, which is going to be more higher thought processing or more autonomic reflex and sending signals, just a relay center. Which one is it? It's like a relay center. So what does the spinal cord do? What's its purpose? Well, it coordinates reflexes. We just kind of said that. It helps with locomotion. Locomotion is, movement. It utilizes these structures known as central pattern generators. Central pattern generators are, what allows us to produce a coordinated activity using several muscle groups. So it allows you to walk. Because to walk, it's not just a couple of muscles, like two muscles that are being fired. It's a sequence of muscles, right? And then if you want to walk with purpose and have a little bit of a swagger, right, then it takes even more. But the way that we all walk, I mean, you asked this question about recognizing a voice, a person's voice, right? You also can appreciate this. You see someone coming your way, they're silhouetted because the sun's setting, and the way they walk will give you some clues as to if you know that person, right? If you know somebody really well, you know the way they walk. You know their central pattern generator. And the way that we all walk, our locomotion, our gait, for those of you that are exercise science, gait analysis is huge. Not just for patients and PT, but also for athletes looking at gait analysis. And I'm not just talking about watching film. I'm talking about analyzing the motion of the biomechanics over and over again to determine, for a quarterback, you're releasing 0.02 seconds too early, right? Or you're jumping off the line for the lineman 0.02 seconds prematurely and you're getting called offsides or false start. So these pattern generators are huge, and this is what the spinal cord does. This is information that's passing between our peripheral nervous system and the brain. So in this slide, I refer to this as peripheral nervous system, PNS. And then in the future, we're going to talk about the sympathetic nervous system and the parasympathetic nervous system that also, as you can see, might have similar abbreviations. So here we're talking about the peripheral nervous system and the brain. That's the purpose of the spinal cord, is to connect the outside nervous system, the periphery, to the central nervous system. Now, we have parts of the spinal cord. This should sound very, very familiar. Now it gets, I think, a little bit easier because we have a foundation of the brain, the central nervous system of the brain, and we can see we have meningeal layers, and this is contiguous, like what we talked about with the dura, the superficial most. Then we have an epidural space that's between the dura and the arachnoid. We have a subarachnoid space. That's where the cerebrospinal fluid is. And then touching the brain or touching the spinal cord is the pia mater. So it's the same organization that we had up in the brain, which is why we said that cerebrospinal fluid, it comes from the ventricle system and it circulates all the way down that spinal cord and then into the arachnoid villus. This is a very common orientation of a prep that we're going to look at, a spinal cord prep. So we're cutting it in a transverse section like this, and then you're looking at it from the top. You'll see the vertebral body in the back in the posterior aspect. In the anterior aspect. You'll see the posterior aspect, the spinous process of the vertebrae. And then contained within this bony casing, similar to what we have in the brain, right? Protecting the spinal cord, because this is completely surrounded by bone. Now you have another vertebrae on top, and so you'll study this in lab, you have two vertebrae on top, and there's obviously a gap in between because unlike the brain, we actually need this to bend, right? And you can't bend it if it's just a solid column of bone. So that's the purpose of having these vertebrae, and we'll talk more about them. But it's kind of an interesting architecture. What's housed inside of here, same strategy as what we had up in the brain, is all of the important stuff is housed within this bony process. So the major regions of the spinal cord, we have the cervical region, which is the neck. That's up top. We have a thoracic region, right? So there's 7 cervical vertebrae. We have 12 thoracic vertebrae from about here to here. And then we have 5 lumbar, which is lower back. And then we have 5 sacral, which is your sacrum, basically like your tailbone is what we call it. So 7, 12, 5, and 5. Best way to remember this, breakfast at 7, lunch at noon, dinner at, if you're 55 or older, dinner at 5, and, dessert, a little bit after 5. So now let's look at a sagittal view. So you can, the way that we're viewing this from the posterior aspect, but it's a sagittal view. So from the posterior aspect, the cervical region has a concave angle to it. We call that cervical lordossus, like this. Does that make sense? I'm looking at it from the posterior aspect, this direction. So this is concave. The thoracic is convex. We call that thoracic kyphosis. Then the lumbar is, again, concave, lumbar lordossus. And then the sacrum, sacral kyphosis. Those are the lordoric or kyphotic angles of the spine. What's interesting about this is when you're developing in utero, what is the shape of the spine in utero? It's C-shaped. So it's going to be kyphotic, right? It's going to be like this, C-shaped. Wolff's Law tells us what? Remind me what Wolff's Law tells us. The bone will adjust or remodel based upon the stresses or forces placed on it. So when that young infant that's born with a C-shaped spine starts lifting their head, what does that do to the cervical? It completely remodels to a concave lordoric angle. See that? The thoracic kyphotic angle stays the same. Where does the lumbar lordoric angle remodel? When does that start happening? When they start standing and walking and they start taking their weight and they're putting their hips underneath their head, arms, and trunk, and that completely remodels the lumbar lordotic angle. So these pediatric milestones of lifting the head and walking, like they're important for spinal development. Interesting, right? So if you have a delay in walking or a delay in lifting the head, you might anticipate some abnormalities at the level of the spine. Okay, continue on. So we're going to walk through just each one of these regions: cervical region, the thoracic region, and then we'll finish it out today with the lower back, the lumbar region. Now, the cervical spine supports the head, provides attachment sites for muscles of the neck and the upper extremity, and it protects the spinal cord, of course. But it needs a large range of motion because it's kind of balancing the head on top of the peak of the spinal cord. So we've got two unique bones. We've got the atlas C1, cervical 1, and the axis C2, or cervical 2. The atlas supports the skull. This concave superior articular facet is where the skull actually sits, and this supports the motion of moving the head in the sagittal plane, or saying yes, right, like this. The axis has this cool little feature known as the dens, or the odonic process, and it's held in place by ligaments that attach to that, and we're going to look at those ligaments here in a second. And it actually facilitates this motion of no. But you can obviously articulate these and do, a full circle because of the ability for these to actually move across each other. So here's how they fit together. You can see the axis, or C2, down below. You see this transverse ligament that goes right in front of the dens, this transverse ligament holding it in place. Now, we're also going to see from this view alar ligaments that actually attach to the side of the dens. Right? So these ligaments hold these C1 and C2 in place. Now, what happens when you have an injury, like a rear-ended collision that's unexpected? It's hyper-exaggerated if the patient's head is turned, but that's not uncommon. Like you're in traffic, right? And you see in the rearview mirror, like, oh crap, they're not slowing down. And what do? You look back, right? You look back and you're like, bam. And that puts this pressure, aggressive pressure, on the ligaments. And particularly the alar ligament is quite susceptible for strain or rupturing. And so it tends to be the main, most commonly injured ligament in whiplash injuries, is 66%. There could be, further damage. A subluxation is just a term of like dislocating that joint. And you have both destruction of the transverse as well as the alar ligaments in very extreme injuries. These can happen in sporting activities too. It's not a rear end motor incident is not the only way that this happens. Okay, now we're moving more inferior to the thoracic spine. This is the transition between the cervical spine, 5 vertebrae. Thoracic has 12. And it's an integral part of this thoracic cage that holds all of your vital internal organs. Now, again, back to this view. We're looking at this structure. We see that it's got a slight wedge on this thoracic kyphotic angle. This is a very normal thoracic kyphotic angle, where it's going to be longer on the posterior aspect and a little shorter on the anterior aspect. Can you appreciate that? Because it's like a piece of a pie. Because originally it came out of a circle, right? The C in the embryonic, developing in utero. So this is considered normal kyphotic angle. But what we do see in patients, especially as patients age, we see what we call a severe thoracic kyphotic angle that's secondary to osteoporosis. So what does that sentence even mean, Keller? Severe thoracic kyphosis secondary to osteoporosis. Who can explain what that sentence actually means? It's a very medical case study, but what do you think that means? That's exactly what it means. This patient has osteoporosis. We learned about that, right? She's probably postmenopausal, so estrogen, the protection of estrogen on the bones has worn off. And because of that, the bone density all throughout the body is compromised, but it's leading to this excessive hunchback. That's exaggerated thoracic kyphosis is basically a hunchback that we see in elderly patients. You see it in men too, but it tends to be more prevalent in women because of this onset due to osteoporosis. It also increases the likelihood of fractures. And so these fractures that can take place, let me just see if I can dim these lights real quickly. It's going to get real dark, but don't get excited. So can you see where these arrows are pointing right here to this vertebrae in the thoracic region? Or we've got compromised vertebral bodies due to this exaggerated thoracic kyphosis and the pressure that's being implemented down onto the thoracic spine. Okay, as we kind of wrap up today, we're going to finish up with the lumbar. But again, I want to encourage you to stay this whole time because I've got something for you at the end. And it's not stickers, even though you all deserve stickers, but it's not that. The lumbar spine, lower back. And in lab, when you look at these, do you think that these are going to be the thinnest and the smallest and the most delicate of the vertebral bones? No, they're the most stout. They're the biggest. They have the largest body. They have the most bone mass because they're carrying all of the load from the superior aspect that we just got done talking about. You got a big head and a big brain and a big skull, and you have all of this head, arms, and trunk, right? All of that is being supported right here at the lower back. So they have to be the most pronounced. And they experience tremendous loads throughout your day. You don't even think about this, but if you measured with a force transducer, and there have been studies that do this, the amount of load pressure that you have on your lower back, it's surprising we don't have more back injuries, but we do have lots of back injuries. So many of you are going to be PTs. How many are going to be PTs? Let me see. Okay. How many are going to be physicians or nurses? Occupational therapists. Okay. You're going to have a lot of back injuries, and the most common back injury is in the lower back. Okay, it's not the old lady, sweet old lady that's got the hunchback. That will happen. It's not the individual that got rear-ended. That will happen. It's going to be mostly lower back injuries. You need mobility, so it can't just be fused. Although that's one of our strategies when we have repetitive injury is we start fusing vertebral bodies together with metal surgically. So continuing on this theme, let's take a look at a herniated disc and what is it. So in between the vertebral bodies, we have a portion of a disc that's made out of what? What tissue is that? It's not bone, it's what? Cartilage. Very well done. Cartilage. So these structures or these discs are shock absorbers, right? So they're actually allowing for the compression from the weight above so that you don't have bone on bone. So on occasion, they can become damaged and they can, what we refer to as herniate, or there's a bulge. If that bulge compresses one of the nerve roots that comes out, you get a lot of pain. The patient experiences a lot of pain. So we call this a herniated or a slipped disc. Now, the surgery that involved here is pretty extensive, but it can be done pretty quickly. So if the intervertebral disc lies in front of that spinal nerve, then it's going to be carrying about 80% of the load through that level of that disc, right? 20% gets distributed around kind of the sides, but 80% is going right through that disc, and it's bulging and putting pressure on the nerve. L4 and L5 and S1 are the most prone to wear and tear and rupture because L4 and L5, there's 5 lumbar, they're the furthest down, and then S1 is the first of the sacral bones. And in all of us, the 5 sacral bones are fused now. As you get older, they fuse. They start in embryonic development as 5 bones, and then they fuse into a structure known as a sacrum because there's not a lot of cartilage between the sacral discs. So disc surgery, this is a CT scan. This is an MR scan. The CT is a little easier to see. Here's the disc. Here's the bulge right here. And the idea is to come in and remove that to alleviate the pressure. So this is being removed. Here's the bulge. There's 2 structures in the disc. There's a annulus, which is the collagen architecture on the outside. The annulus holds in the gelatinous disc material that's on the inside. And the annulus is made primarily of collagen, and it's made in a thatched pattern. And so when you're in this position, the collagen structures are crossing like this. When you twist, they do this. And then when you come back, they do this. When you twist this way, they align. When you twist back, they cross. Where do you think they're the strongest? Here or here? Here or here? They're the strongest when they're crossed. It's more like an irregular, dense connective tissue. Over here is a regular connective tissue where they're all aligned. The biggest risk for patients is this motion. Twist and bend. And pick up something heavy. So what do we tell our patients? We say, don't twist, turn, bend with your legs, and grab it. But don't twist, bend over, and pick up, the 20-pound whatever Amazon package off the front porch. Okay? Does that make sense? When you know the architecture and how it all fits together, now you can explain to your patients, hey, I'm not just telling you to take an extra step and do this because I want to see you squat, okay? Because I think it's funny. It's actually science, okay? This is actually how it's designed, and it's weakest when this is all aligned like this. And that's this motion when you twist. So that annulus is where that cross architecture, that hatch, that's the structural integrity of the disc. And the inside is just it's like jelly. It's like a jelly donut. And so here you've got the torn annulus, and you have an extruding disc. And so these patients would feel this paresthesis or pain. Paresthesis is a word that means that numb pins and needles feeling, like when your foot goes to sleep. Or they're going to feel pain because they're getting pressure directly on that nerve root. It's really, really annoying. So the surgery, pretty simple, maybe an hour and a half procedure. There's probably, 3 hours prep and hours afterwards. But the actual procedure that the neurosurgeon or the orthopedic surgeon would do would be to come in here between the vertebral bodies and surgically remove the disc. If PT, you unload the vertebral body, and then this could reabsorb. If it's torn, if it's bulging, you can probably PT your way out of it. If it's torn, you're probably going to have surgery. That would be the sort of the decision point, right? And you remove this and you reattach that annulus, and then this kind of fills back in, and now you've alleviated pressure off of the nerve root.
You're able to, the physician's able to see if it's torn or not on the CT or MRI, right?
That's right. You would use imaging to be able to discriminate a torn annulus or not. But most of them are going to tell you, I'll use imaging to make the decision if I should recommend surgery, but I won't know really until I get in there, right? Because they want to see it with their own eyes. That's what surgeons like to see or like to do, which makes sense because you're trying to make decisions off of black and white pictures, right? So
You'd be able to see it visibly torn if you're in the surgery, right?
yes, you would. You'd be able to see if it's visibly torn if you're in surgery. Okay, last lower back issue, which is also very, very common, is a term known as spondylolisthesis. This is the forward or the anterior slide or displacement of a vertebra, especially the fifth lumbar vertebrae, that often happens after a break or a fracture. And you basically, instead of them lining up, one slides forward and puts pressure. So here's an image. Let me turn these lights off again. This is an image, an older male, birth date 1946. So hopefully, I don't want to block anybody. 1946. So, and this was done in 13. So this was done, 12 years ago. So this patient now is 78. Back then they were 66. My math is horrible. But do you see right here? See the body here and the body here? The superior portion of this vertebrae and the inferior portion of this vertebrae and they're not lined up. Do you see how they're off? And you see this portion here, how they're off? That's spondylolisthesis right there. And that's putting all sorts of pressure on the lower back, on those nerve roots, creating all sorts of discomfort for this patient. And in this case, one of the best things to do surgically is to alleviate the pressure, shift, and then you come back from Home Depot and you put 2 plates on either side with screws. Not really, but kind of. Okay? Really fancy Home Depot, right? Stryker and Zimmer. Questions? Questions over material today? Okay, pause. And bear with me. So Monday is going to be a lighter lecture, but we will have lecture. And the material is testable material. The exam is on Wednesday.